Sage Weekly News Briefing. Thank you everyone for joining us. To begin with short presentations from two of Independent Sage's members, then we're going to move on to questions from journalists and members of the public, and we'll hope to get through as many of them as possible. Okay, so I think we'll start with Professor Christina Pagel, who is going to present the week's figures. Christina.
Hello. So, welcome to today's briefing. So the headlines are that new cases are continuing to go up and hospital admissions are rising, but there is a sign that it might be slowing down slightly, the rise. So I'll dig into that. Also where they are, who they are, and then thinking a bit more about the start of the university term. And then finally, just end with some recent data that's come out. It's still under peer review, but it really shows the importance of communication and support for self-isolation. So this is the number of new UK confirmed cases in people who've had a positive test. Again, I've labelled where we first started getting problems of testing in the beginning of September, and cases are shooting up. I mean, every week I have to increase the scale of my y-axis, which is not a good sign. But we know that these numbers are not actually an accurate reflection, so they are going up a lot. But we also know that loads of people can't get tested. Here's just a screenshot. This is what's happening at the moment. It also tells you not to call the helpline, so it's not quite clear how that's affecting the numbers when they track NHS 111. And for instance, Sadiq Khan said today that London's had 40% fewer tests over the last couple of weeks as resources have been diverted. So this is still an ongoing issue, and it just means that these numbers are difficult to interpret, but it's easy enough to see that cases are still going up. I thought this was just quite an interesting plot from the NHS test and trace data. And it's just looking at tests in the community, and they break down into the kind of tests that I would get or you would get, where it's a drive-in or a walk-in or a home test. And then what are called satellite tests, which are mainly the ones sent to care homes to help them manage the outbreak. And you can see since the beginning of September that the number of tests distributed to care homes has gone up, whereas the number of tests in the other community settings was going up and then went down last week. So I think what we're seeing there is the government prioritising care homes, which I do think is the right thing to do, but also it does highlight that it is quite difficult to interpret our case data. This is showing positivity rates. So this is the proportion of new people tested. So people who haven't been tested before, who test positive, regardless of the route they're tested in England, Wales, and Scotland. And again, it's a bit difficult to interpret because we don't know exactly who's getting tested now. And it's a little bit confusing about how people who are regularly screened get into this population, but you can see it is steadily going up. And in Scotland, kind of has a sharper increase over the last week than England and Wales. And I'm going to talk a bit more about that because part of that might be the fact that they started university earlier than we did. So how many new infections are there if we can't really trust the case data? So the Office of National Statistics released their latest survey today, and I quickly downloaded the data. And they have daily estimated number of new infections. This is in England only. Based on their sampling of people every week. And this is slightly different numbers to the PDF because that's a weekly number and these are daily numbers. And what you can see here is you can see this kind of flat thing over the summer. And then they were estimating 3,000 new ones on 24th of August, 6,000 new ones a week later. But then only today are they almost 12,000. So it looks as if growth has slowed slightly over September, and that is a good thing. So here we had a week's doubling time, and here we've got 3 weeks doubling time. And if that is real, then that is really good news. However, these grey shaded bits show the uncertainty. So there's a lot of uncertainty in that. So, and you can also see from this shape that it looks as if there was kind of a slowing down, and then just over the last couple of days, the speeding up again. So that's something really to keep an eye on. The COVID symptom tracker app from King's College, which has 4 million users, is another way of trying to get at this. And there the picture is a bit less rosy. So this shows the number of people that they estimate who currently have COVID symptoms in the UK. So it's not daily infections, it's people who currently have symptoms. And here you can see 8-day doubling in the second week of September, and then it's gone down to 6 days in the most recent week. And I just checked again this morning, and it's gone up to 160 something thousand. So they are seeing a less rosy picture, and it's quite hard to know how that fits in with the Office of National Statistics survey. We can also look at new hospital admissions, which isn't as affected by the testing, and actually does kind of show more severe disease, because that's people who need hospital from COVID. There were 268 new admissions. This is England data only, on the 22nd of September, and that compares to 175 on the 14th of September. So when I was giving this presentation last week, I said there was 8-day doubling up to this point, and now we're 8 days later and we haven't doubled. So, there's a sign that maybe the hospital doubling time is also slowing. And then I showed you last week, when it was 8-day doubling time from here, where we should kind of be by now. And you can see that we've dropped off it. And that's a good thing. And actually fitting it to 8 days ago, it looks more like we're now exponential growth doubling every 12 days. And this is important for 2 reasons. And the first thing is just to point out that the 8 days, it's not a given thing. We know that if left to its own devices, COVID will double in a kind of susceptible population every 4 days or so. But we haven't left it to its own devices. We're doing things to slow it down. And so that's where we were 8 days. And we've carried on doing things. We've had more restrictions. People are, being more careful about social distancing, about mask wearing. And it does seem to be having an effect. And although this kind of difference here doesn't look small, if you zoom out another month, it actually makes a really big difference. And that's kind of, although these kind of steep increases is the danger of exponential growth, the beauty is that making small changes early on can really impact where you're going to go. So even just the small difference that we've seen over the last week buys us 9 days to get to 1,000 new admissions a day. And I picked 1,000 new admissions a day because that's roughly where we were when we locked down in March. So the more we can do this through our own behaviour, the better it will be for us. And ideally, ultimately, what you want to do when testing and tracing is back in place is get that down to 0 doubling time and go down to shrinking time. I mean, that's ideally where we want to be. That's when R is less than 1. So where are the cases? So you can see again that really the spread at the moment is very much concentrated in the north and northeast in Yorkshire. And it's also spreading now in London. The Office of National Statistics also found exactly the same thing in their different way of assessing cases. So we're seeing that at the moment it does seem to be kind of in these 2 areas, although it is still spreading in other places. And in terms of who's getting infected or the ages of getting infected, this is from the Public Health England report, and it only goes up to the 13th of September, so it's a bit of a lag. But you can see that although in August it was mainly the 20 to 29-year-olds, it is now in September spreading to older age groups, which is probably driving hospital admissions, but it hasn't got to the over 70s yet. And that's a really good thing. And we should try and make sure that it doesn't as much as we can. And that will, again, keep hospital admissions a lot lower. And in the week to the 19th of September, in the report released today, ONS saw the highest rates in the 17 to 24-year-old age group. So they would be in these red sections here. And the reason that's relevant is I think it does correlate with the start of university terms. So in the same Public Health England report, they look at confirmed COVID outbreaks by type of setting. And particularly, this is one looking at education. And you can see most of them are in schools, secondary school and primary school. And you can see here that this is the first week of term. It does start to go into universities. But again, this only goes up to the 13th of September, and we have seen quite significant spread at universities, particularly in Scotland. This is data from Public Health Scotland up to the 22nd of September, looking at infection rates among age groups, and this is the 15 to 19-year-old age group. So people kind of in their last few years of school, but also their first year or two of university. And you can see that it's really shooting up. And the next biggest age group is the 20 to 24-year-olds. And that kind of coincides with the headlines that we saw that came out yesterday of new restrictions on Scottish university students who are now being told not to go to pubs. And a Guardian article today saying that, thousands of students UK-wide are now being forced into isolation. And there are even talk about not letting people go home during term time and not letting them go home over Christmas to stop the spread. And I think, as UK term starts for real this week in England, and Wales, I think this is going to be an issue. And it's an issue not just for the spread of COVID, but also very much for students' well-being. I mean, remember, these are people who, for many, it's their first time away from home, and now they're in quite, potentially frightening situation where you're having to isolate in a small bedroom, and you're being told you can't go out and do the things that other people are allowed to do. And that's not a unique problem to us. This is just a graph from the Netherlands dashboard of their outbreaks, recent outbreaks. They started university term on 2nd of September, and almost 40% of their outbreaks are in educational settings. And apparently nearly all of that is in universities. The Washington Post reported this week that actually that's across the whole of Europe. We've got thousands of students in quarantine. And the Guardian had this map yesterday of confirmed outbreaks. And at the moment, a lot of them are in Scotland because they started earlier. But we should, I would expect this map to get worse over the next week. And I think it is something that we as a country have to think about quickly, how we're going to support students and universities and the local communities to deal with this. So I kind of was saying that even moving from 8-day doubling to 12-day doubling can have a really, really big impact in reducing its spread and reducing the impact on the NHS and people's lives. And there are things that we can improve. I mean, testing is the obvious one that has to get fixed, but there are other things that we can do right now. And this is all based on a survey or a series of surveys done of people since since I think April to August, and looking at understanding of COVID symptoms and whether people were isolating. And the first kind of graph that really caught my eye is that only about half of people up to mid-August correctly identified the most common symptoms of COVID. Only half. And if that's the situation, there are going to be a lot of people out there who aren't self-isolating because they don't know that they have it and they don't know that they might have it. And that is something that we could fix right now with a really, really strong public messaging campaign. This plot shows that people who have symptoms of COVID, only about 20% of them actually did self-isolate properly. So 80% of them reported leaving the house in the previous week while they had symptoms. And that's not because they didn't want to self-isolate. So 70% said they intended to self-isolate and only 20% managed it. And that's because it's hard. But this is something that we have to prove. And this is why it's so important to support people when they self-isolate. And perhaps unsurprisingly, even fewer people who are contacts of people who have COVID are self-isolating, only about 10%. And that's kind of expected in a sense, because most of these people will feel absolutely fine. And again, 70% of them intend to do it. And so I think thinking about how the government's put in these big fines for not wanting to self-isolate, it's not that people don't want to do it, it is that it's really, really difficult and a really difficult thing to do not to leave your house for 14 days. So this is where we can now put in place structures and financing and support to help people do this, because this is really how you can bring down infection. So just to kind of summarize, I said this last week, I think it's still true that a combination of steep increases in cases, increasing spread across the country in ages, and increasing hospital admissions and a broken testing system has left us in a dangerous place. That is still true, and it hasn't changed. Doubling time seems to be somewhere between 7 and 12 days. They might be longer even from the ONS survey. It's quite uncertain, but there is some sign that it has slowed a bit, and that is good news. And hopefully that will continue as people's behavior changes. That said, the contribution of university terms starting to transmission is concerning. We're seeing continued spikes in infection in that age group. And it's also concerning about students' well-being. And I think we have to be really careful about how we support these young people. And just finally, fixing testing must remain a priority, but it has to accompany rebuilding the whole of the find, test, trace, isolate, and support infrastructure. And that includes communicating what the symptoms are, supporting people who have symptoms to self-isolate, and supporting people who are contacted to self-isolate, especially now with the launch of the contact tracing app. It won't work if only 10% of people actually isolate. And then finally, just continue to move capabilities to local communities to support a really strong test and trace infrastructure. And that's it from me.
Thanks very much, Christina. Well, the fascination with exponentials, I think it's vital. Hopefully next week you can show us a third curve where doubling time has slowed even further. But I guess that's the point. We don't know. On the one hand, we've got the government restrictions coming in with bars, restaurants, pubs closing at 10, which hopefully will have some effect. On the other hand, as you say, in university starting again. I was at Surrey this week. My students, I feel so sorry for them because these are 18-year-olds, first time away from home. This week should have been Freshers' Week when they're all going wild and making friends and starting their new life, and they're all walking around with face masks on, thankfully, keeping their distance. So let's hope that doesn't have a major impact. Okay, so can I just ask now Professor Gabriel Scally to report on two new papers very briefly. The first is a policy paper on the issue of population immunity. The second, just a few words on a briefing note on the example of Sweden and some of the information surrounding the Swedish model. Gabriel, over to you.
Thank you very much. I'll start with the paper on population immunity, as you said, Jim. We think this is a very important paper, and we put it together because the idea of population immunity or herd immunity emerged early in the UK government's response to the pandemic. And we thought that the idea had died away, but it has seemed to be brought out again at this late point as we struggle to cope with a potential increase. Our paper is titled A Deliberate Population Immunity Strategy Before a Vaccine, Why It Wouldn't Work and Why It Shouldn't Be Tried. Let me try and explain what population immunity, herd immunity is. It's the concept that once a population of people develop individually immune responses that protect them from getting the virus, that the virus will not have enough unexposed people in order to spread around that population. So that means that the virus will be repressed. It doesn't mean that the virus can't be reintroduced, because new cases can come in from outside, as we unfortunately know, but it does help to repress an infectious disease. We rely on population immunity for some common illnesses which are now uncommon, such as measles, mumps, rubella. Measles is a good case in point. A dangerous disease in very young children, and again produces ill effects in older people as well over the age of 20. But we've successfully controlled that for a long time through vaccination efforts, the MMR. Unfortunately, although we had met the standards for elimination in the UK, a fall off in vaccination rate enabled transmission of cases in the UK, and we now get every year outbreaks of hundreds of cases of measles, sometimes with devastating consequences. So it can be a useful tool, but it's not the solution, and it's certainly not the solution to all diseases, not even one for which we have an effective vaccine such as measles. We believe it is not feasible in the case of COVID-19. Firstly, we don't know enough about the natural history of the disease to know that it's feasible. We're still learning about this virus, and particularly the immune response to the virus. We do know that there may be a problem with the duration of the immune response. So some of those people who perhaps had the virus in the early phase may be losing their immune response over the next 6 months or 9 months. So it's not quite clear at what point we ever would have a very substantial proportion of the population with an active immune response. We just don't know. And anyone who says otherwise is speculating. We don't know the duration. So we don't know enough about it. The second point I want to make is that for it to succeed without killing large numbers of people, because what it essentially means is letting a very substantial proportion of the population become infected in the hope that they will not suffer and that we manage to protect the vulnerable. And some people advocating this approach have talked about aggressively protecting vulnerable people, the elderly, frail, disabled, people with pre-existing conditions. There is no real definition of who we should be protecting. And 30% of the UK population have a condition that would indicate that they have a vulnerability to the disease. So there's a difficulty of deciding who should be protected in this aggressively protected group. And I think there's also a real issue about who will do the aggressive protection. It also raises questions as what that would do to our workforce. You will all have seen those terrible montages of photographs of NHS care workers who died, unfortunately, during the peak of the pandemic earlier this year. They were active workers in the NHS and care workers. We don't know how many of them would have to be, for others like them in the workforce, of, for example, of the NHS, would have to leave that workforce under this definition of people who should be aggressively protected. It could cause enormous problems. There's a further problem in that if we decide that there is a percentage of the population that is at really high risk and should be protected, there will then also be a very substantial proportion of the population who have a moderate or even a low risk.
Did we manage to print it out?
But we are assuming that they will be that they will get the virus and not be affected. But if you affect millions of people, all of whom are at low risk or moderate risk, you will undoubtedly have a lot of deaths in that community. We also don't know what the long-term effects of the virus is. It's not a harmless virus, and long COVID is an extraordinarily serious problem about which we are only learning. We also don't know whether there will be long-term effects stretching forward decades, particularly in terms of people's brains and their brain function. It's entirely feasible that infection with a viral agent could predispose people to neurodegenerative conditions, perhaps as a result of a further viral insult later in their lives. So it's not a harmless virus, and we don't know the extent of the harm, but we do know it is harmful. A further problem that we identify is that the adoption of a population immunity approach may increase inequalities. We already know that this virus is at its most potent and at its most prevalent in our deprived communities, in those that are overcrowded in their homes, and particularly vulnerable areas with high levels of people from Black and minority ethnic groups. So there is a real danger that any population strategy of people becoming allowed to become infected may disadvantage the already disadvantaged even more. The fifth reason we think that this strategy is flawed is that we have usefully used the time since the pandemic started to do research, not just the research into the all-important vaccine, which hopefully will be seen sometime during the course of next year, but research into the treatment of those that do fall ill. And some promising treatments have been developed, and there are undoubtedly more trials that may give us more ways of reducing the death toll. It would seem to us to be wrong now to encourage anyone or permit people to have a preventable infectious disease when we know that it's extremely likely that we may have drugs and treatments which could protect them from side effects should they develop side effects of their infection. The final point is that we know what we need to do to suppress this virus and keep people healthy. From its inception, Independent Sage has been arguing for a public health approach to a public health pandemic. And we still strongly believe that the development of a find, test, trace, isolate, and support system that works and works for everyone is the single most important thing we should do. I quote from the last line of our paper. If I can find the last line of the paper. I can't. We should not give up and pursue a population immunity strategy just because building a good test, trace, and isolate system is difficult. And I think that is our final point on this issue. We haven't really tried to repress this virus. We haven't built the find, test, trace, isolate, and support system we need. And it's about time we devoted our attention to that and are not diverted by further discussion or exploration of a strategy for population immunity that, in our view, is going to be ineffective, ill-informed, and impractical. Thank you very much, Jim. So if I can just quickly say about the Swedish paper, there has been much discussion in the press and in the media about the Swedish model as a way of approaching handling pandemic in a country. We've been concerned about this because we have noted the very different performance of the Nordic countries, Sweden, Finland, Denmark, and Norway. And we are extremely concerned that that model may be given some credence. We believe it is ineffective. Sweden has had an enormous number of deaths per head of population, 5,880 deaths, representing 581 deaths per million population. Compared to its neighbors, it has been unsuccessful in preventing deaths. Finland, for example, has had exactly 343 deaths, which equals 62 deaths per million population. And we see little attention paid to the strategy pursued in Finland, which has been highly successful, or the strategy pursued in Norway, which has been similarly successful. We draw particular attention to the economic aspects because we understand very well that we can't have full public health without full economic health. The latest data, which we quote in the briefing note from the European Commission, shows that Sweden's performance in terms of its likely performance with GDP this year and its performance next year in GDP is not out of line with Sweden, Finland, Norway, and Denmark. And we can see no merit in Finland being held up as an example to us. Some of the myths we expose, for example, that Finland hasn't done any social restricting, they have. They closed schools for children 16 years and older and colleges. They have done more than the UK in some respects by halting travel from EU countries, the UK, and by not halting travel from EU countries, the UK and Switzerland, but halting travel from the rest of the world, whereas the UK has pursued an open border policy. So there are some aspects in which Sweden has taken action, but the action they have taken falls far short of what is needed to control this pandemic. And we would urge people to look at the experience of the Nordic countries, to read our briefing note and draw their own conclusions. We're very clear what the story really is. Thank you very much, Jim.
Thanks very much, Gabriel. Okay, so now we move to questions. And our first questioner is our special guest today, who's Michael Rosen, a children's author, poet. Michael, I should say, is it's particularly great to have him on today because he spent 47 days on a ventilator after being admitted to hospital back in March with COVID-19. So Michael, it's really great that you're back amongst us and getting back to hopefully to full health. Over to you.
Thank you very much, Jim. So as you say, I was infected at the end of March. I was in hospital in all for 3 months. So I had the effects, if you like, both of COVID and of being in intensive care. It's quite difficult to sort out which is which. And I guess my area of questioning is around this area of long COVID, long tail COVID, as it's being called. And it was lovely to hear Gabriel touch on that. So here's an illness that we know causes fatality. It has flu-like symptoms at one end of it, as we say. The other end for some people, tragically, of course, is death. And then there's a whole other group of us who are walking around with long-term and lifetime effects, some of which we know are lifetime, like this ear, it doesn't work. And I've been told by the audiologist won't work again. I've got a scan to come to find out exactly why it won't. And an eye that's fogged that doesn't look like it's going to unfog, and various other things. So really, I suppose my question for you at Independent Sage is, what kind of a picture do we have of long COVID in terms of people reporting symptoms for 2 months? Some of us who got infected quite early, that means that we're now 3, 4, even nearly 5 months, I think, post-infection. What sort of stats have we got on that? And then, of course, some of us are being told that we do have lifetime effects. I've hardly seen any literature anywhere on that, even though I've been told, and presumably other patients have been told, well, that bit of you ain't going to work again. So it's a general question about the picture. If we don't have statistics, that doesn't matter, but a general picture about this thing that I'm going through. Thanks very much. Thank you.
Thank you very much, Michael. Before I come to you, Anthony, Gabriel, you wanted to just make a point of clarification.
Yes, thank you, Jim. I think when I was talking about Sweden, I sometimes used Finland instead of Sweden and got my Scandinavian countries mixed up. I would encourage people to read the paper. All will be clear in the explanatory note. Thank you very much, Jim.
Thanks, Gabriel. Okay, Anthony Costello, do you want to come in on Michael's question?
Michael, this is an incredibly important topic. We don't have enough information at all, but it could be one of the biggest impacts of the entire pandemic. As far as I know, the data from the COVID symptom study suggests that 15% of people don't recover quickly. In Italy, 87% of people like you who were admitted to hospital were still struggling 2 months later. Brain fog is a very big problem, and people think that may be to do with inflammation of white matter in the brain. And then heart damage. This is not just a respiratory virus. Growing concerns about the scale of heart attacks. My wife had one 3 months ago, but myocarditis and other impacts on heart muscle and indeed many other organs. So this is a really important thing. We know that the immune centers in your spleen and lymph nodes may be shut down by the virus or severely impaired. 2 papers came out yesterday in Science, which showed that one was on autoantibodies, that you can make antibodies against this thing called type 1 interferon, which protects you normally. And the other is a study of inborn errors of type 1 interferon, which also shows that people like that are much more vulnerable to the effects of COVID and get it very severely like yourself. So this is a very big issue. And you only need, if the heart effects are true, you only need like 1% of those people to go on to have serious problems, to be a massive economic problem for our health service and the like. So I think this is a really important issue, and I thank you for raising it. I'm so glad to see that you're back, hopefully able to write a bit more.
Yes, indeed, I am. Thanks very much. And I've written quite a few things since, and even about this. So that may emerge at a later stage. Thank you very much, Anthony. And I'm very concerned that it isn't more of an issue, as you say, but I've said my piece. Thank you.
Thanks, Michael. Martin McKee, did you want to come in on this?
Yes, I did. So we will be producing a report on this in the near future. And wearing another hat, I'm also leading a small project, writing a report for the World Health Organization European region. I think we can distinguish 3 broad groupings within this. One is people who've been on ventilators in intensive care, and there is a well-recognized post-ICU syndrome, which can last for a very long period of time. Being ventilated is not, as you know, a pleasant experience. And it's not just that, actually, there's also a ICU relative syndrome as well. The relatives and friends of those have psychological problems often as a consequence of it. The second is the more general post-viral syndromes, which are well established with a range of viruses. And the third are the very specific effects of this particular virus. They're not absolutely specific. You do get them with some other viruses, but they are relatively so as a function of where they bind on to different receptors. As Anthony has said, the neurological system, the cardiovascular system, and also the kidneys, and some evidence of the islet cells in the pancreas being affected as well. So we will be trying to pull all of this together. The difficulty, of course, is that we will not know, perhaps for a very long time, historically what we do know, even from 1918 and from the flu then, and long-term consequences of that. It may be that some of the complications only appear after quite a long period of time, but for the meantime, there is some rather concerning evidence of abnormalities that can be detected several months later. How long those persist for, what their clinical significance is, it's not altogether clear, because some of the people who are being studied, like elite athletes, are being looked at in a great deal of detail. But we are trying to make sense of all of this and come up with something that will, but the other thing I should say is that a number of very prominent colleagues have had this or are suffering from that and have been writing. And I'd pay tribute to Nitri Nalwan from Southampton and Paul Garner from Liverpool, who've been very eloquent in their descriptions, and also colleagues like Trish Greenhaw at Oxford, who's been trying to pull together some of the work and in terms of guidance for health professionals. So watch this space. We're pulling it all together as far as we will be able to, but it's very much work in progress.
Thanks very much, Martin. And again, Michael, we all wish you well, and hopefully your recovery, if not 100%, is at least gets you almost back to normal. Our next question is from Dr. Phil Whitaker. Now, Phil is a GP, he's a novelist, and he writes the New Statesman's Health Matters column. Phil, over to you.
Hi, Jim. Sorry, I think I can see on my camera. I'm quite in the dark here, so I'm not delivering.
We can see you.
Yeah. Thank you for inviting me on. I think, yeah, I mean, long COVID is a very interesting subject, and I see a lot of people affected in general practice, but perhaps you've dealt with that. But I think the other thing on my mind is this week we've had finally the track and trace app has been launched, which once upon a time was said to be absolutely vital to our response. And looking at Christina's figures, perhaps around 10% of people contacted by our extant track and trace system using human operators are actually isolating if they've been contacts of positive patients. How useful is this app going to actually be? And what, I guess, would the panel do to make it more useful if it's not deemed to be particularly helpful at the moment?
Susan, I guess this is for you.
Thank you. Well, I think the app was only ever proposed as part of a bigger test, trace and isolate system. So on its own, it's not going to make a huge difference. But we're in a situation where every little bit counts. And I think Christina's figures earlier showed that. So we can't take our eye off the ball of improving, finding the cases at one end of the fine test, trace, isolate and support system, or indeed at the other end of the support. So even if there was huge uptake of the app, if there's not the support there, when people either have the symptoms themselves or are a contact of somebody who's got the symptoms, then it won't add value. And what we know from the study that Christina presented, that I was a co-author of, is that the main reasons why people aren't isolating for the 14 days is partly financial, partly they have caring responsibilities outside of the house, and partly they need to go out and get go shopping and get medicines, etc. So the good news from that point of view is that these are all very fixable problems at a national level by the government. This could be tied in with the app. The app's not enough on its own, but we do need to see rapid action. And last week, Professor Carl Friston's model was presented, which showed that I think the efficiency of this test, trace and isolate system only needs to be increased by just over 30% for us to actually begin to see a rapid change, but it needs to be done very quickly.
Thanks, Susan. Zubaida, did you want to make a comment?
Yes, I mean, just very quickly to echo Susan's point, I think we do need everything right now to be thrown at test and trace, given that Dido Harding's test and trace system has been shown not to be fit for purpose. So the app in that sense could certainly help. Or if you like, our concerns about the app is that there are teething problems with it. We know that there have been issues with iPhone 6s and so on. But more importantly, there is absolutely no point in having a test and trace unless we can get people to self-isolate. And I think that's where the biggest issues are. And that's where the government, I think, while they look as though they're taking some steps forward, have actually taken several steps back. So just this week, we saw Boris Johnson announce that finally they're going to financially support people to self-isolate. We know that's been one of the strong reasons why people haven't been able to self-isolate, because they don't have that financial security. Now, Boris Johnson suggested £500 to self-isolate for 2 weeks, which sounds generous, but here's the rub. In order to get the £500, you need to qualify for it. And the qualifications criteria is high, including, and this is where it's almost humorous, including the fact that you need to get a positive test from the NHS Test and Trace app, from the NHS Test and Trace. But we know people can't get a test at the moment. They can't get a test, just as Christina has shown. So if you can't get a test which shows that you're positive for coronavirus, you can't apply for the £500 to self-isolate. On top of that, sorry, Jim, I'll be very quick. On top of that, the other measure that Boris Johnson has proposed, that if people don't self-isolate, they will be fined £10,000. Now that is an absurd amount, first of all, because that's not how you get people to adhere to any measures. But secondly, £10,000 fine means that anybody who has COVID is unlikely to let, or if they suspect they have COVID, is unlikely to let the test and trace people know that they have COVID, let alone let them know that their friends may have been in contact with them. So we need to consider the whole picture here, and there are real worrying signs that the government is going backwards with self-isolation measures.
Thanks, Zubaida. I do want to move on. Dean, did you make a quick final comment on this? Okay,
Jim, let's move on.
Thank you very much. Okay, so our next question is from Doina Cornell, who's Labour and Cooperative District Councillor for the Gloucestershire town of Dursley and leader of Stroud District Council. And she has a question about testing capacity.
Thank you very much. Before the current crisis, we had a functioning local system of testing, for example, blood tests using GP surgeries and clinics accessible in every community and local lab, with results coming back very promptly. Why aren't these being given resources to build extra testing capacity in every part of the country? Each would only need to take on a little extra to share the load, and then people testing positive would be known to local community health teams, GPs and nurses to help them self-isolate. Is something like this being done in other countries, or is the COVID testing system always set up separately?
I'm sure many of you have probably something to say. Yes.
Thank you very much for that question, and you're absolutely right to identify the question of why we're not utilizing existing structures. There is no doubt as well, though, that the capacity that we do need is very large, but that capacity, in our view, could have been built from that integrated base that you've mentioned, which is the whole system of primary and secondary care, working with laboratories, data being managed according to NHS guidelines and firewalls, public health access to data, and therefore the test and the tracing being integrated there. What has happened is the separation of these functions according to these so-called pillars, whereby pillar 1 represents the system you mentioned, and pillar 2 are the lighthouse labs, which are managed in a completely different way. And what is paradoxical is, as the lighthouse labs have increasingly found it difficult to continue to increase capacity because of short-term staffing, because of procurement problems, and so forth, in fact, more and more of pillar 1, in other words, NHS laboratories, are taking on that responsibility. Well-recognized cases where samples that are waiting in lighthouse labs to be tested are actually moving back to pillar 1 laboratories. In Newcastle, I understand the new lighthouse lab that's being developed is going to be managed by the NHS. So to some extent, by default, things are moving back to that system. But if we started there, things would be much better. And I think at this stage, it's not too late. And I've said before that if Baroness Dido Harding, if only she would bring together, under the umbrella of the National Health Service and public health services and local district public health within the UK, then actually we could deal with this capacity issue. But as things are set up at the moment, I think it's very difficult to move forward. Thank you.
Thanks, Lula.
Thanks. And just to add to the point that Dean's made, because you mentioned experience in other countries, we can say that, you know, we are dealing with the pandemic, but we have dealt with outbreaks that are both of short-term duration and longer, more protracted epidemics or endemics in other countries. And some of the lessons that we learned are exactly what Dean is mentioning. So not in addition to the advantages of having the access to those data, the two other aspects that we've learned. One is around trust and engaging, which is really important, engaging communities. So working with the existing structures, working within those makes it more likely to build up that element of trust to get the community on board, which is we've been talking about, so critical to test, to isolate, to share contact, etc. But the second indirect impact is also on other pre-existing conditions within the health system. So we also know that, you know, we know that it never works out better to have a parallel structure because that has negative implications for other pre-existing conditions. And so we know that it's really important to think comprehensively, because we can deal with COVID, but as we mentioned, there are the long COVID implications, which may not fall under a COVID umbrella because we see it in so many different parts of the health system. So I think these are two additional reasons why it's so critical to have an integrated approach.
Thanks, Sarula. Okay, so our next question is from Claire Hasty about long-term. So I think this is very linked to Michael Rosen's question about long-term, long COVID and who was hospitalized. Over to you.
Thank you. I started the long COVID support group on Facebook, which has almost 23,000 members. And I want to call for your help, please, in helping us to get long COVID into the dialogue. One of the key reasons I think it's not spoken about enough is that it's not measured, as has been touched upon earlier. We need to move the narrative away from deaths, cases, positive cases. Many of us fell ill in March before testing was available. Testing is now difficult to access as well. And I also want to emphasize that help needs to be given urgently for the vast numbers who were not hospitalized. So many of us might have gone to A&E multiple times and been practically crawling through the door, but because we didn't hit a certain threshold with our SATs levels or whatever it was, we were sent and left to languish at home. And several studies now are demonstrating that those of us who are not hospitalized are seeing symptoms of a severity, duration, and breadth. In some cases more than those who were hospitalized, even those on ventilators. So the government investment in the FOST COVID study is welcome, but it focuses on hospitalised patients. The Your Recovery website is welcome, but we need face-to-face investigations in multidisciplinary clinics to rule out some of the organ damage that we know from research affects those of us who are not hospitalised as well. We cannot be given websites to tell us to exercise and give us rehab until we've ruled out myocarditis, pulmonary embolisms, all of these other risk factors. So we need your help, please.
Thanks, Claire. That's such an excellent point. Does anyone want to respond? Martin, yes.
Well, just first of all, thank you for everything that you're doing in raising visibility yourself. I can assure you that both through Independent Sage, we will be doing it, and many of us in our own individual capacity. As I said, I'm convening a group for the European Regional Office of the World Health Organization that will be putting out a report on this. And you may have seen, if you follow on Twitter, Hans Kluge, the regional director of WHO, who did actually tweet about 10 days, 2 weeks ago, on this, about saying that he is making it a priority, as are a number of other governments in Europe, in fact. So I think at an international level, it is now getting very much on the agenda, but I think we all need to keep, I think we also need to challenge the people who say young people have nothing to worry about. This is, you know, not many people, young people die. That may be true, but I think we need to constantly reinforce this message. They may not die, but we do know that there are a non-trivial number of people who are left with significant problems.
I would agree. Our group has people, a lot of us have children with it. My 3 children were affected, babies even. Your stats before about students are quite frankly petrifying, because our group is full of people in their 20s, many of whom were highly active, no previous health conditions. So the risks to the public are not in the narrative. It could be any of us.
Anthony and then Christina. Oh, you're still muted, Anthony.
Basically, any organ that has ACE2 receptors can be affected by this virus, because that's where it binds. I was talking to an expert on ACE2 yesterday, and he said, he asked me, which is the organ with the highest concentration of ACE2 receptors? And he said it's the testis and the fallopian tubes. And that was interesting, because I'd never heard that. Now, we don't know whether the effects there will have any impact on fertility long term, or maybe on the endocrine, the hormonal aspects of, you know, sexual organs, which could underpin some of the symptoms. But you're absolutely right. This is potentially a massive issue. And I'm fairly sure that the Medical Research Council Wellcome Trust and the NIHR, the National Institute for Health Research, will be putting a lot of money into this. I would certainly hope so. But maybe Martin knows more about the European funding side.
Christina?
I just wanted to add to what others are saying, that I just think this is so important. It's not talked about enough, and it's partly, you know, what prompted us to write something on the kind of population immunity strategy, because it assumes that it is fine for younger people to get it, and it isn't. There was a study in the States that showed that 1 in 5 people in their 20s still had symptoms after 3 weeks. I mean, that wasn't that long, but that's, you know, that's 20% of people. And then there's another study I read this week that showed that something like women were like 4 to 1 more likely to get long COVID, even though men are more likely to get severe disease that ends them up in hospital. Women seem more likely to suffer from long COVID. I don't know why, but, you know, we desperately need to research this and understand it. It is a new disease. And I think any kind of comparisons to flu are really unhelpful.
Thank you, Christina. Okay, so our next question is from Melanie Pownell-Harris, who's going to ask a very interesting question about what to do in airports. Have I caught you by surprise? And is she there? Oh, I don't even think her name is there, actually. I think she may have left us.
Hello.
Oh, you are here. Oh, good.
Hi. Hi. Thank you very much for considering my question today. Following the recent report that trained sniffer dogs are being used in Helsinki airport to detect people with COVID-19, I believe this offers massive potential to allow us to return to a normal life. dogs would detect asymptomatic and pre-symptomatic people, ensuring these people are stopped from spreading the virus. The dog sniffing results are immediate and non-invasive. We could have many dogs trained to detect COVID-19 sufferers in our midst, including being posted at significant places and walking the streets and on public transport. What do you think?
Who would like? Do you want to come in?
I think Dinan's an expert.
Come on, Dinan's the airport expert or sniffer dogs expert.
Thank you. So thank you, Melanie. I read the same as you, and it's all very interesting. Of course, dogs, you know, I'm not personally more familiar seeing dogs sniffing for drugs and so forth, but they can be trained, and there are projects within the UK. I think London School of Hygiene Tropical Medicine is hosting a project also about training dogs for sniffing whatever it is that COVID tastes of or smells of. But more broadly, all these things are useful, and I don't want to put a damper down it, but it's maybe a little bit like the question around the app, that we've got to not be tempted into thinking here's the solution to what is a public health problem. And if dogs are going to be added to apps and to vaccines and to new tests that are going to suddenly be the magic bullet, I think we're going to be disappointed. But of course, anything that helps will be useful. And of course, I also think about dogs identifying or through this way infections, also akin to approaches, for instance, for testing sewage for virus, which can also be used in sort of almost like mass testing to identify where outbreaks are happening. So all these things can be added in, but as long as they're added in a well-functioning public health approach. Thanks.
Thank you, Dinan. And moving on to this, the issue of apps, we have a question from Helen Raywood, who is, I think, one of many people who's probably a bit nervous about downloading it. Helen.
Hi. So my lack of trust in the government is what is preventing me from downloading the app. And with all the government's past and continuing failures in regard to COVID, I can't believe that it will be of any use, especially with the collapse of test and trace. So am I right to be cautious?
Susan.
Hello. Thank you for that question. And I think many people all over the UK will be asking that very question. Unfortunately, the trust in the government's handling of this pandemic has been decreasing all the way along, and is now about 30% of the people trust the government. However, although we know that not trusting means that people are less likely to adhere to the guidance, I think we need to have great confidence in the people of Britain to kind of resist thinking just because the government has advised this, we're going to be suspicious. And all of the suggestions about physical distancing, about restricting, is all done for a purpose, which is to try and stop the transmission of this virus from one person to another and from one community to another. So this app, the first app that was presented by the government, had all the data stored centrally. And there was great opposition to that for many reasons. This app is the same app that, in essence, that has been used in Scotland, Wales, Northern Ireland, and I think the Republic of Ireland. And the data is stored with you, and you can get rid of the app at any time. The data doesn't go beyond the local, your local phone. So I have downloaded it. I'd urge other people to download it. I've been told that the results of the pilot testing in the Isle of Wight and Newnham will be published any day now. I think we just need to review it, see if there are problems, ensure that that is raised. I think there is a website where you can communicate problems. But I think at this stage, every little bit helps. And if it seems a sensible thing to do, I think we should do it, whatever our views of the government's handling of the pandemic are.
Thank you, Susan. Okay, so as we come up to the hour mark, time for maybe one or two more questions. So the next one's from Julie Taylor, who's a concerned mother. Julie.
Hello. Right, I'm a mother of 4 children. I've got triplet boys in year 8 in secondary school and a year 10. I'm very concerned. We're all on the app from King's College, and I have seen there the recent report about the symptoms in children, including young people, and how they differ from adults, which seem to me to be very significantly different to the information I'm being given, under what conditions I should keep my children home from school or indeed be allowed to apply for a test. The reason I really wanted to ask the question today is I have 2 pieces of paper here. One, Dear Parents and Guardians, 23rd of September, saying, if your child is feeling unwell but doesn't have a temperature, cough, blah, blah, loss of sense of smell, they do not need a test, whereby obviously the King's College reports completely different symptoms, including 51% not even having a fever. I've also now had, and it's not the school's fault, I really would like to stress that, they are obviously just following the advice they're being given. I've received a 2-pager telling me all the reasons why, unless my kids have got adult symptoms, I don't need a test. What does the panel think?
Would anyone like to comment on that? Yeah, Christina, thank you.
I mean, I think that they definitely should take into account that children come up with different symptoms, you know, the 3 classes of symptoms. I suspect they're not because they don't have enough tests. I mean,
I can promise you that the app actually told me to get a test and I couldn't get one.
But it should be, and I think in general they should widen it. I mean, there's only 3 symptoms. Most countries have, you know, 11, 12 symptoms like the WHO recommends. And at the moment it's very restrictive. So I'm hoping that that will change once they can get their capacity up. I mean, I don't really know the logic of just using those.
Thank you, Christine. I hope that answers your question, Julie.
Not really, but I mean, my worry is, as you all know, same with the long COVID problem. You know, my 14-year-old is a young adult. His voice is broken. He's taller than me. As far as I'm concerned, he could very easily end up as one of those long COVID children. And I think it's totally misrepresenting children every time they mention them to not differentiate between secondary and primary settings.
That's a very good point. Thank you. We have time for one last question, which is from Rebecca Goulding about businesses and working from home. Hi, Rebecca.
Hi. Yeah, that wasn't my question.
Oh, that wasn't your question. Oh, well, okay. I do apologize. Look, ask the question you want to ask. Ignore me.
That's okay. So, yeah, my question was that yesterday, the media was reporting that we'd reached the UK's highest daily total of COVID-19 cases on record, which on the surface is suggesting that cases are an all-time high. But very few people were being tested back in March and April. So how do current figures actually compare to those from that time?
I'm sure Christina has the figures at her fingertips, but yeah.
Well, I mean, you're right. Like saying we had the highest figures. I mean, it's nonsense. It's just, it's just nonsense. There's no point recording that. Like they were thinking we were having well over 100,000 new infections a day at the height of the pandemic, and we're not there. And also the case numbers that we're getting don't reflect how many people have it because we're not testing so many people. So I've been looking at hospital admissions. So on the first date that we have hospital admissions for is the 18th of March, and it was 390. And so we're now at about 270. This is England only. And if it was doubling every 4 days, then 14th of March would have been around just under 200. So we're probably approaching 14th, 15th of March levels. I mean, that's my guess, but it's a guess, but I think that's a reasonable guess.
Yeah, it's never been clear to me whether stating these figures as the highest ever is journalistic laziness, or is it something, some sort of policy to scare people into abiding by the recent rules, because clearly, we're so many more people now. So the positivity test, I think, is something we've discussed in the past. The fraction who are tested positive is a much more useful number, but obviously a much harder one to get hold of. Well, I think that is all we have time for. Thank you everyone for joining. Of course, this is being recorded, and I, for one, are going to go back and have a look at the recordings, look at Christina Pagels' hugely informative plots that, well, not your plots, Christina, clearly the plots that you've dug out, which are very, very informative and useful. I should also say that the papers that Gabriel talked about on population immunity and on Sweden will also be available on Independent Sage's website as soon as possible. Thanks everyone again. Thanks all for joining us, and we'll see you all next week. Bye-bye.
Bye.